A 70-year-old gentleman was referred to us for endosonography for obstructive jaundice. Patient has severe cholestatic symptoms and was suspected to have a lower bile duct block on other imaging studies without definitive diagnosis. So as I had discussed earlier in few cases, a standard protocol, EUS mapping of the pancreatobiliary anatomy and pathology followed by a definitive intervention. You can see the dilated bile duct, periampullary tumor occluding the lower CBD, you can see here. It could be arising from the pancreatic head. There's absolutely no doubt the lesion is appearing fairly resectable as none of the major vessels are close to the primary lesion, as you can see here in scanning. However, minimal free fluid was seen. You can see in the pericholecystic area, minimal free fluid was noted, and there were few lymph nodes also we saw. You can see the lesion very well now, and its dimensions are somewhere around 2.5 centimeters by 2.8 centimeters, and it's our experience that any tumor beyond 2.5 centimeters you can see the dilated pancreatic duct. I'm still sitting in the duodenum. You can see the free fluid pocket at 12 o'clock position. This heralds a very early peritoneal dissemination. Of course, it can be debated whether we always need to do any USFNA of the small pocket of fluid. But when we know that these patients are highly comorbidities, and for definitive palliation, diagnosis and staging, it does not really matter. You can see the mildly prominent pancreatic duct here in the body of the pancreas. We'll evaluate any pancreatobiliary tumor to have a celiac axis lymph node or not as a standard protocol. We need to see celiac axis, celiac artery area. We are trying to see the celiac artery, and this is the celiac artery area. You can see small round sub-centimeter hypoechoic nodes. Now people can definitely debate whether these are reactive nodes secondary to cholangitis or these are definitive metastatic nodes. It's our experience, 5 mm node, we have done an FNA and they turn out to be metastatic. So this is the new thinking. I personally reckon that the world will have to follow perhaps in times to come when more centers starts doing EUS routinely for all pancreatobiliary cancers worldwide. You can see here this is the aorta at 5 and 6 o'clock position. That's the standard position we keep for mediastinal evaluation. And as I withdraw, I'm seeing sub-centimeter lymph nodes in the supradiaphragmatic, subcarinal, periesophageal, periaortic region. These are round hypoechoic nodes, mind you. So we need to really look into this science of staging any pancreatobiliary cancer before definitive treatment. And I personally reckon that tumors which are deemed resectable on conventional imaging, including PET-CT scan, should undergo an endoscopic ultrasound prior to a definitive resection or treatment, because you may pick up small lymph nodes which can influence the staging as well as eventual outcome. You can see here the tumor is brought between 5 and 7 o'clock position. Once again, we are using a gentle jab with a very small 25 gauge needle, and we will deplug the needle with the stylet, and it's our standard technique over last 7,500 FNAs that we have done and learned lessons out of it, that there is no need to really wriggle your needle very aggressively in the lesion, because that can lead to a lot of blood. So very gentle to and fro, very, very gentle maneuver of the needle within the tumor up to the periphery of the lesion. We stay there for about 30 to 45 seconds, and that's end of the procedure, and this is enough material we have aspirated out of the lesion. Now, as I mentioned, whenever we have a pancreatic head or periampullary lesion, there is resultant periampullary edema due to obstruction of lymphatic channels. And you can see here significant periampullary lymphedema leading to impossible cannulation even and the deformity in that region. So we do try certain techniques, but then it really doesn't work always. So we change our technique here. We are doing a pre-cut with a sphincterotome now. So what I did, I know that this could be pancreatic duct. We know that there is a pancreatic head tumor, and that pancreatic duct tumor is occluding the pancreatic duct anyway. And there is severe deformity, and no way I will be able to find the right plane to cut in the axis of the bile duct. So I managed to engage the catheter and de-roof the opening. So we know that there is somewhere is the opening, and we have de-roofed the topmost layer. Now, once we have done this with a conventional sphincterotome, I can see some opening there, some bulges. So very gently we will take a needle knife sphincterotome and then peel the onion of the ampulla. You can see here very gentle maneuvers, a very gentle cut here we know, and then I'm using a specially designed biliary dilator, a 7 French tapered tip with a terumo, because sometimes these tumors are extremely tight and very sclerotic in order to negotiate. So here you can see that our guide wire has gone deep in the intrahepatic biliary system. We always make sure that we are in the IHBR and not in the gallbladder. And then inject contrast. You can see that the entire biliary system, you can see the cystic duct take off there. So it is important for you to ascertain that you are right in the intrahepatic biliary system. We are evaluating the stricture also. You can see the lower bile duct completely occluded with the neoplastic process on cholangiogram. And then we exchange the terumo for a stiffer guide wire once we have obtained a cholangiogram. So this is our standard practice. You can see dark bile coming out. Now this patient, as you can see, has minimal free fluid. You can see the brush. It's a standard practice because of our study protocol that every patient with obstructive jaundice, we will do EUSFNA as well as brushing. And we have compared our data, and I think there is no doubt that EUSFNA is much superior and more accurate. And I think slowly and surely, as more centers starts doing EUSFNA routinely, the practice will change significantly. So in this case, though ideally this patient warrants a metal stent, but because of certain socio-economic reasons, patient's relatives insisted to have a plastic stent, as they think that they need to evaluate this patient for resection if required. So I said, perfectly, it's fine. So we placed a catheter, and over the catheter a 10 French Teflon stent. Now I prefer Teflon stents purely because of the stiffness of the stent. And I think PTFE stents are not, or polyurethane stents are not very good in certain situations when the strictures are too tight. So I personally feel that this kind of stents can take any severity of stricture, any sclerotic nature of the stricture, and it slides easily. Again, Teflon stents have low coefficient of friction and therefore the occlusion rate is comparatively lower than the routine plastic stents.